Next speaker is Jeffrey Weiss.
Thanks, Dr. Sachter. I have fear of the bell, so I'll try to talk like I'm double parked here. Talking a little bit about some of the underpinnings of nocturia, including neurourological. Just some basics. Lesions of the nervous system that cause neurogenic bladder and voiding dysfunction. Lesions above the pontine center for micturition, loss of voluntary control, but with coordination of the detrusor and the sphincter. That's safe, but wet. On the other hand, suprasacral spinal lesions, they are not safe. They're involuntary contractions of the bladder against a closed sphincter because of the lack of synergy, and that's the most dangerous lesion that leads to upper tract renal deterioration. Thoracolumbar lesions are interesting because you have detrusor areflexia and sphincter areflexia. So now you have the paradox of urinary retention and incontinence due to sphincter weakness and fixed sphincter. Sacral lesions, on the other hand, detrusor areflexia, but the sphincter is functional, so those patients are in urinary retention and need to do something to empty, but they are not necessarily incontinent. So here's, I think, a basic look at the nervous system as it relates to the bladder, with a little bit of homage to Branislaw Onufrevich, who right here in 1899 described that nucleus, which is the origin of the pudendal nerve that innervates the external urethral sphincter. So during storage, the pontine center for micturition is inhibited by the higher centers in the brain. Activities in the hypergastric nerve and the pudendal nerves keep us continent, keep the bladder relaxed through stimulation of beta-3 receptors in the bladder body, and inhibition of the parasympathetic stimulation of muscarinic receptors also in the bladder body. Now, when a bathroom is available, those inhibitory impulses from the prefrontal cortex and other centers in the brain are removed, and now the periaqueductal gray can interact with the PMC to initiate micturition. Now we have a turning off of the sympathetic. Sympathetic makes you store, through the hypergastric nerve makes you hold, and now we get a turning on of the parasympathetic side. Parasympathetic makes you pee, and happily the pelvic nerve, so easy mnemonic and hopefully unobstructed micturition in the neurologically intact patient. Now, Rebecca Haddad did me a big favor in advance of this talk because she did an entire review of the literature of nocturia and nocturnal polyuria in neurological patients, from epidemiology to treatment. Rebecca's a urologist in Paris who is doing her research year at Ghent University, which is actually a hotbed of nocturia research. So we have a lot to nocturia, not necessarily just in neurological patients, but literally in all patients. All patients, whether or not they have a neurological condition, will have aspects of renal physiology problems and cardiovascular problems, primary sleep disorders, hormonal disorders, and all of the specialists who deal with these various organ systems can be helpful in the evaluation and treatment of patients with nocturia. So all patients start with a history of physical urinalysis, post-mortem residual. We don't want to miss anyone in urinary retention. But then the mainstay is not invasive procedures. It's not urodynamics. It's not cystoscopy. It's not prostate biopsies. It's a voiding diary, a simple frequency volume chart for 24 hours to determine whether there's, for example, a mismatch between nocturnal urine production and bladder capacity. That's where this nocturia index, which is the quotient NUV, nocturnal urine volume, divided by bladder capacity, or maximum voided volume, is greater than 1. Or whether they simply put out too much urine at night, for example, from third spacing or obstructive sleep apnea. And if they put out more than a third of their 24-hour urine output in the hours of sleep, they have nocturnal polyuria. And if they have diminished nocturnal bladder capacity, that's yet a double whammy. So once we get these diagnoses, these categories of nocturnal polyuria, which we which then gives rise to a gamut of underlying medical causes that we should seek and treat. We have low capacity. Here's where the neurogenic bladder really resides, in the low capacity, but it's low capacity can be caused by prostatic obstruction, pharmacologic agents, stones, cancer. Don't ever want to miss cancer. And then my favorite, polyuria, global overproduction of urine, let's say in excess of, let's say round figures, around 3 liters. All of this is another hour lecture, so I don't want to go into details about all of these. But classification in this scheme unlocks up to 19 significant medical conditions, all of which can be, or any of which can be present in the neurological patient. So when we have low capacity, the urologic problem, it's not necessarily a renal problem, not necessarily a cardiovascular problem, that's where neurogenic bladder sort of lives. But all these patients with neurogenic bladder, let's say involuntary contractions after a CVA or with Parkinson's disease, they may also be present in patients who have other conditions, let's say in a man, prostatic obstruction, or perhaps a person that has a chronic cystitis, perhaps interstitial cystitis, or even tuberculosis, and certainly cancer. So we don't want to just make any assumptions that, okay, it's a neuro patient therefore has a neurogenic bladder. That patient can have nocturnal polyuria, can have prostatic obstruction, can have bladder cancer, and a variety of things. So in the study that Rebecca Haddad did, she focused on epidemiology, diagnosis, and treatment. And we looked at levels of evidence, and she looked at levels of evidence there. And in terms of high quality evidence, you don't get too much, but what we know is that nocturia is frequent in Parkinson's disease patients. She's looking at the big 4, really Parkinson's, multiple sclerosis, spinal injury, and stroke. In terms of causes, lower tract dysfunction, overactive bladder, or neurogenic detrusor overactivity are plausible causes. Cardiovascular dysfunction, non-dipping of urine, which can cause pressure natriuresis and overproduction of urine. So that's not really a problem with the bladder. It's a problem more with the kidney and excretion. And yet these are patients with neurological disease. So you always have to look at other causes of nocturia than just simply what is wrong with the nervous system. And then the treatments, well, you'll see here that the highest quality data comes from companies that want to sell you stuff, like the people that make desmopressin. There's your level 1 evidence. Okay, desmopressin is good for probably almost anybody with nocturnal polyuria, unless they have a serious problem like heart failure or renal insufficiency. TENS units in patients with overactive bladder. Probably multiple studies done by people that manufacture these units, but pelvic floor muscle therapy can be useful. Overactive bladder drugs, not great. These drugs have not, all the studies are retrospectively, none of these are prospective studies on neuro patients, and consequently the data is really not very good. So now we looked at the etiology of nocturia in patients without nocturnal polyuria but low capacity, and we found that they improve, when they do improve, with 4 mechanisms. And the mainstay is that it's very hard to increase bladder capacity. What is much easier is to decrease the waterfall, decrease the input. So we really focus on measures to decrease urine output, even when the baseline urine output is not high. This kind of puts it together. Again, nocturia, H&P, urinalysis, diary, post-mortem residual. We get the categories. Low capacity is where neurogenic bladder lives, but all of these categories can contribute to nocturia, and they should not be missed in your neurological patients. Thank you.